welcome to the Only You podcast with Dr. Lauro Amezcua-Patino. I'm Barbara Schulte, a psychiatric nurse practitioner. Welcome back, and thank you for joining us. Today we're going to talk about bipolar disorder.
Thank you, Barbie.
Thank you.
And thank you to the audience again. Thank you for spending some time with us, and hopefully you can send them some questions and we can answer some of your concerns about mental health issues. And also, if you have any topics that you want us to cover, please send us on the website.
Yes, absolutely. So today we're going to talk about bipolar disorder. What is it? How does it come about? Who has it? Who doesn't have it? So what is it?
Well, I think it's important to understand that bipolar, the word bipolar has become a kind of a colloquial word that is used in society now to describe anything that is intense, right? Yeah. Or anything that tends to change ways a lot. So people will talk about their dogs being bipolar, their phone being bipolar, you know, my marriage is bipolar. So it's important to understand that bipolar disorder is a serious disorder of the brain.
Yes.
And it's called bipolar because it's got two poles. Okay. In the older days, for me being an old person who has been doing this for 30 years, we used to call it manic depressive illness.
Okay.
And it still is a term that is frequently used because it describes the two poles, depression and mania. Okay. All right. So we call it bipolar to separate it from the unipolar depression that is regular major depressive disorder. So just for starters, we need to recognize that bipolar disorder is a serious illness that is not something we should be taking lightly. And it's a term that it shouldn't be colloquial. It's a term that should be used seriously because it's kind of offensive for people that suffer from the disorder, you know, to be hearing, my dog is bipolar. I mean, those kinds of things are not very nice to people who suffer from the disorder. Yeah. And it's not a disorder of character, it's a disorder of the brain. So it usually affects about, I would say, 2% to 3% of the population. Okay. And it can be pretty disabling. Right? Okay. So as you probably know, the symptoms of depression comes in two poles. The depression pole is no different than having major depression, meaning people tend to feel tired, have no motivation, they feel sad sometimes, they feel very indifferent, they have difficulty concentrating, they have sleep difficulties, either sleeping too much or sleeping too little. They have increased or decreased appetite. So if you have a patient who comes to you or is suffering from those symptoms, that's no different than having depression. In order to make a diagnosis of bipolar disorder, you have to have had mania or hypomania. What does that mean? Mania is actually a disorder where you have the opposite of being depressed, meaning that you are very euphoric, you're very racy, you have very fast thoughts. Yeah. You talk very fast. You may have ideas that you have powers other people don't have. And it can get into delusional thinking, right? Some people start spending a lot of money they don't have. Yeah. And it's fairly typical. When you see classic mania in the euphoric sense, if you see it once, it's fairly easy to recognize. And it has to last consistently for about 1 week. Or so severe that you end up being in the hospital, right? In general, people with mania do not ask for help because they feel great.
Yeah. So it sounds like a good time.
Well, it's a great time. I mean, it's probably the best experience you can have, and it's consistent, and you feel fantastic. So hypomania is a lower degree in which you don't necessarily go into the most severe grandiosity or delusional thinking, but you're still pretty fast.
Maybe some irritability.
Irritability is another side of mania. So you have to have either the classic euphoric mania or you can have irritable, angry mania, right? I have to tell you that over the years, I've kind of noticed that the quality of mania has changed over the years. We don't see as much of the classic euphoric mania like we did 30, 40, 50 years ago, and we're seeing a lot more irritable mania. But again, is the consistency over time that becomes important?
Yeah.
Because we tend to call people who switch moods during the day as having bipolar.
Yeah.
That's not bipolar. If you're happy in the morning and sad in the afternoon, that is not bipolar disorder. You have to be consistently depressed for a period of time, consistently manic, euphoric, or irritable for a period of time.
So typically, bipolar disorder has two features: depressive episodes and manic or hypomanic episodes. So
Correct.
the combination of the two classifies someone as bipolar. But typically we look at someone's whole life in order to make that assumption, right?
Correct. Well, you see, I like movies. So when I think of psychiatric diagnosis, I think about somebody's movie of their lives, right? So in order to make the diagnosis, you need to understand how things have progressed. So you have to look at from the time they were born to now, how this movie happened, right? What kind of events happened in the movie that may have had an impact in the development of this person? So psychiatric diagnosis is about movies, and it's about intensity and frequency.
Okay.
So how much and how often? And then number 3, what is it doing to you? So you have symptoms, you have intensity, you have frequency, and then you have dysfunction, meaning what is the illness doing to you? How is it affecting your day-to-day functioning?
Yeah.
Let me just go on a side for a minute. It's like if you have attention deficit disorder, and parents always ask me, do I have to give my kid medication? I say, well, it depends. What is the illness doing to your kid?
Yeah.
So if your kid's not learning, is not making friends, is not relating to people, is procrastinating, is not doing homework, well, maybe the medication may help with those dysfunctions that the kid's having.
Right.
The same thing happens with bipolar disorder. So the decision to treat is not just because you have something, it's because of what that something is doing to you.
Yeah.
Right?
Absolutely.
Yeah.
And so there's obviously children and adolescents who suffer from bipolar disorder as opposed to adults, and the combination. When do you typically diagnose bipolar disorder?
Bipolar disorder can actually be diagnosed at any age. Okay, It's more frequently diagnosed in middle to late adolescence, right? Different than major depression. Usually major depression is an illness of mid to late 20s, early 30s, right? However, the fact that you have depressive episodes in adolescence does not mean you have bipolar disorder, but it raises the suspiciousness. So we have to think of it more, right? Just statistically speaking, major depression, also known as unipolar depression, is a lot more frequent than bipolar disorder. So if you have a patient that comes to you with depression in general, statistically speaking, is more likely to have major depression than bipolar disorder.
Right.
But there are other features that make you think of it, right? So we talked about panic disorder in adolescence, for example. That raises your suspiciousness. We talked about the depression in general of bipolar disorder is identical of unipolar depression. However, there's some little details. For example, being melancholic as a teenager, especially young teenagers, is rare. So when you have a melancholic, and we'll talk about what melancholia is.
Yeah, I was going to say, what do you mean?
So if you have a melancholic adolescent, then you have to raises your suspiciousness. Melancholia means that you really slow down, that you're really sad, withdrawn. I mean, when you see a picture or a depiction of depression, you see somebody who's down, sad, head down, not moving, talking slowly. That's melancholia. Okay. Right? Okay. Different than the traditional adolescent who gets depressed angrily. So interestingly enough, when you have an adolescent who's angrily depressed, it's probably unipolar depression. Yeah. But when you see somebody who's very melancholic, that's rare to see with adolescents. So again, it's not diagnostic of bipolar disorder, but it raises the suspiciousness. Another feature is in my business, in our business, is something we call misadventure with antidepressants, right? For example, this is fairly typical. The patient goes to the family doctor. The kid's depressed, has a full major depressive episode. The family doctor decides to start antidepressant medication. And then 2 or 3 days later, the kid is very happy, very racy, going 100 miles an hour, feeling fantastic. And everybody is praising the doctor because this is the best treatment I've had.
Yes.
So you have to break the news that you need to stop the treatment because you're creating secondary mania from the antidepressants. That is almost diagnostic, and there's a lot of debate in psychiatry if that really means that you have bipolar disorder.
Right.
For the most reason, it, again, raises your suspiciousness and it makes you look into it because bipolar disorder is a genetic disorder. It runs in families, right?
Which is also problematic when trying to explain that to families.
Exactly. Exactly. Well, in general, nobody wants to have any mental disorder, right? So the idea of having a mental disorder really makes us probably feel bad about ourselves. It makes us feel that we're not good enough, that we're defective, and so on. So it becomes very important that we really pay attention to the history.
Yes.
The other thing is that it becomes a cultural issue too. Families don't like to talk about mental illness.
No,
so you start digging into the family history and you find out, well, we just don't talk about that, you know. So you start looking for certain more dramatic events, for example, a suicide in the family, right? You start looking for substance abuse. You start looking for violence in the family. So you start trying to get more information to see if you can make that movie more clear,
Gotcha.
right? Because our jobs as psychiatrists is to really look at how do we make the next scene and the next chapter of the movie look better than the prior chapters, right?
Right.
But not to minimize psychological and social issues, because, for example, with kids, we do see that kids who have been abused as children have a higher incidence of bipolar disorder. Right, so there might be some cultural, social, psychological factors that increase your risk for having bipolar disorder. Right.
And is it possible that if they are victims of trauma, that their condition may come out sooner than if they had not been traumatized?
That is correct. And we don't know exactly if that's just a purely psychological issue, or it might be a social, interactive issue, or maybe that you're being traumatized because you're being raised by a parent that suffers from the disorder.
Or if they're using substances, that their condition may come out sooner than if they had not.
Yes, and we have to look for the possibility of the patients using substances. Substance abuse is both a complication of bipolar disorder or a trigger for bipolar disorder. So it can happen both ways. Especially in patients who are depressed and use stimulants, we may see some of those patients becoming more irritable. But those issues in particular become very complicated. And usually those are the ones that we get to see ourselves in our specialty.
Yeah.
Right?
So with that, I know it's very common. Sometimes parents are, I don't like to use the word denial, but it's difficult for them to understand bipolar diagnosis or any mental health diagnosis. How often do you hear or have the question, is this going to go away? Is it going to get better? How do you deal with that?
Because we work in the hospital, we see probably the most extensive and worse type of presentations, but there are all gamut of presentations. So when the parents ask me that question, I have to be empathic to their feeling of their child being defective and having a problem, because it becomes very frightening for them. So we have to recognize that parents will be afraid of the diagnosis, number one. Number two, that they want guidance. Right? If we diagnose somebody with bipolar disorder, we have to explain a number of things. One is that the disorder is cyclic, it comes and goes.
Yeah.
and it's chronic. Once you have it, you may have it for the rest of your life. However, it doesn't mean that you're going to be symptomatic for the rest of your life. So it's important to explain. You're going to have some symptoms right now. We're going to try to control the symptoms, learn how to cope with it. And we recommend that you stay in treatment for at least a year to a year and a half of stability, right? And at that point, we can actually look at other options, like start tapering down treatment and see how the patient does.
Yeah.
With the understanding that the illness may come back. Right? If you have only had one episode, one cycle of bipolarity, some patients will not have a recurrence for a long period of time. However, like with any illness, you have to be using some prevention, right? So if you have somebody that's been diagnosed with bipolar disorder, we'll talk a little bit about medications. And let's say they respond well to treatment, you have to advise them for a number of things. Number one, they have to sleep well. Because sleep deprivation is pretty toxic for the brain, and not unusually the illness starts because the patients start not sleeping well. So, for example, they can go to college and they don't sleep at night and they're partying. Well, that if you have had bipolar disorder before, you're likely to decompensate again.
Yes.
They cannot use drugs and they shouldn't use alcohol.
Right.
So sleep is almost sacred when it comes down to mental illness because, as you know, most mental disorders come with some form of a sleep disturbance. So getting the patient to sleep and to sleep at night becomes essential in bipolar disorder. So again, they shouldn't be working graveyard shifts, right? They shouldn't be working nights.
Right.
So we have to make sure that the prevention happens. And that's the most difficult part. It's a lot easier for people to take medications. It's difficult for them to change their lifestyle. But again, that is not just for bipolar disorder. The same thing happens with diabetes, right? Get a patient to follow a diet. It doesn't work, right? Get the patient to exercise. It doesn't work. Get the patient to lose weight now. So we have over expectations of what the medication is going to do. And medications, again, at best, will give you reduction of symptoms, but they will not teach you anything.
Well, not only that, I mean, if you have parents with the same disorder, expecting them to take care of a child with the same disorder, and if they aren't well medicated or well treated, it's almost not very realistic that they will be able to care for a child that way, you know, if it's not been, you know, well managed down the line.
Well, there are psychological and social aspects of the illness that are complicated, like communication styles, anger management. So if you have more than two people in the house who are dysfunctional, whether it's because of bipolar disorder or any other psychiatric illness or personality problems, then it becomes complicated to establish a baseline of normalcy, right? So the intensity of the social and psychological environment also will have an impact on what is happening with the family in general. So sometimes we're going to have patients who we treat as adults, and then they have children, and then we treat their kids. I mean, for me, been doing this for so long, that's not unusual, right? So you have to start educating people and help them psychosocially with the how-to. How do we go about raising my kids? How do I go about dealing with anger and frustration? So again, the therapy is not just like magical, let's talk about why, right? No, it's really practical about how do we go about doing things differently,
right?
And how can somebody give me guidance into how to handle this?
Absolutely. And with that, do you find that, like, for example, you said you've treated parents and children. Do you think that as it keeps going down, it becomes easier or harder? And what have you found?
Well, I think that there is something about how severe your disorder is, right? So not everybody has bipolar disorder has the worst form of it. So there are patients who become totally dysfunctional. They have multiple cycles. There's something we call rapid cycling, people that cycle several times a year from depression to mania back to depression. And that becomes very dysfunctional. We have people that have one depressive episode and they get mostly depressed, and the cycles come and go, and they have had one episode of hypomania or mania in the past, We tend to call that bipolar type 2. And then we have forms of bipolarity where you get psychotic, right? And you have to be forced into treatment. So the whole gamut is really going to dictate what is the individual presentation, because everything in treatment is about the person. It's not the disorder itself, because each patient is going to have different needs.
So like you were getting to, what treatment? What do we talk about with treatment? You mentioned that bipolar disorder has the two sides, mania and depression. Clearly, people will say, okay, let's treat one with one and one with the other, but we don't do that. Well, how do we treat this?
Well, there's pharmacological and non-pharmacological interventions. The most classic pharmacological interventions is mood stabilizers, and the quintessential mood stabilizer is lithium, which lithium is not a psychiatric medication, it's a salt that we use as psychiatric medication. So very effective, in my experience, more effective for mania than effective for depression. Right? Not without complications, because it's a salt, it behaves in your body as a salt. So you have to be monitoring blood levels, water intake, and things of that sort. So lithium is a good medication. Then we have another family of medication called the anticonvulsant mood stabilizers, valproic acid, oxcarbazepine, carbazepine, gabapentin, a number of different anticonvulsants that are used for epilepsy, are also used for the seizure disorders, is also used for mood stabilizing qualities. And then we have a third class of medications called the antipsychotic mood stabilizers that have become very popular, not without complications, but we have very effective medications in that group, and they can also be used as a single treatment for patients that also have psychotic symptoms. So we have a whole gamut of approaches, some of which are more effective for mania, some more effective for depression. The controversy with bipolar disorder is really with bipolar depression, because the controversy is, should we use antidepressants or not? And there are basically two big schools of thought. One school of thought says you should use them cautiously, right? Another school of thought says never use them.
Right.
Right? And I've gone back and forth between the different approaches. And again, if we're going to use them, we have to explain to the patients the risks, right? If we use an antidepressant in somebody with bipolar depression, we may trigger mania. We may trigger irritability. And I think to some degree, we may trigger increased suicidal ideation, because we move people into what we call mixed states, people that have both depression and mania at the same time. And mixed states are very dangerous. I always tell people, if you get irritated and depressed at the same time, and you have racing thoughts and you're agitated, it probably has one of the highest risks for suicide in psychiatry.
Yeah.
So bipolar mixed states are something that we have to be able to recognize quick and treat fast.
Yep, because you have energy, but you're depressed.
Yeah, you're sad and energetic at the same time. That's a really bad combination.
Yeah, not a good combo.
Yeah.
Okay, so I think we've got the treatment. You've just kind of given us the information about the diagnosis itself. Do you think that the difference between when you are a child with bipolar disorder or adolescent and then when you get to adulthood, the changes that you experience, I know in my experience, children with bipolar disorder tend to have much more mania, hypomania, and then when they move into adulthood, it tends to be more of bipolar depression, and they have much more of the depressive side. Is that what your experience is?
Kind of, but I think it's more of a factor of recognition, meaning we tend to underdiagnose bipolar, not underdiagnose, we tend to underrecognize bipolar depression because the patient has never had mania before.
Okay.
So what happens is that a lot of the patients that we're treating now with major depression may end up having bipolar disorder and eventually will develop mania. Some of them we discover because of the antidepressant treatment. Some it just takes time, right? So it's important to recognize that a lot of the patients that never had mania before but they have major depression may have bipolar disorder that hasn't manifested yet, okay? So it's easier to recognize those that have mania and irritability, right?
Right.
Because you don't have to have depression to have bipolar disorder, but you must have mania.
Okay.
So depression can be unipolar or bipolar, okay? But in order to have bipolar, you have to have had mania or hypomania.
Mm-hmm.
So that complicates matters a little bit. So you technically you're not supposed to make a diagnosis of bipolar disorder until you have identified mania or hypomania.
Yeah.
That is risky though. So sometimes we have to use our suspiciousness in terms of recognizing that somebody may have a bipolar disorder, and we have to be cautious especially with younger patients.
Absolutely.
Now, bipolar disorder is not without complications or comorbidities. And again, I get back to the substance abuse issue. They tend to be impulsive. So they may run into some issues with the law because they overspend, they don't pay their bills.
Yes.
Some of them may have issues with comorbid attention deficit disorder. And this is fascinating because, especially with kids, in that patients, we like to say that 1/3 of patients with attention deficit disorder may also have bipolar disorder, and 1/3 of patients with bipolar disorder also have attention deficit disorder, right? So those are two different disorders that come to the same patient, and they have to be treated accordingly.
Right.
You have to treat two disorders and recognize them, because the treatment of one is not going to help the other.
Right.
Okay.
And they have to be treated correctly in a balance.
They have to do it in a balanced way. So it's bipolar disorder is a difficult thing to treat. It's not like take 2 aspirins and call me in the morning type of thing.
No.
And I think in my experience, I would say that bipolar depression is one of the most difficult disorders to treat in psychiatry.
Yes.
In general.
Absolutely. All right. Well, thank you very much. I appreciate you letting us know about all of this very useful information. I think bipolar disorder is probably one of the most confusing things that, we talk about, and there's just a lot that we don't even really understand about bipolar disorder, especially bipolar depression.
Yeah, and I think that we could spend hours talking about bipolar disorder and the intricacies, and I think that people may have a lot of questions about that. They may, if they go to our website at theonlyu.net, they may be able to send us some questions, and we might be able to give them some guidance and direction into where to go for that.
Well, thank you very much again, and we will see you next time.
Thank you.
Thank you.